and welcome to this last podcast on the management of supracondylar fractures of the humerus in children. You have now gone through the basic anatomy of the elbow. You have been introduced to interpreting pediatric elbow x-rays. You should be aware of the Gotland classification, and you should be aware of the assessment and management of supracondylar fractures with and without neurovascular injury. The Boast guidelines stand for the British Orthopaedic Association Standards in Trauma. The British Orthopaedic Association and the British Society for Children's Orthopaedics have come together to produce this very important document on management of supracondylar fractures. Supracondylar fractures of the distal humerus are most common fractures around the elbow that are seen in children. They can be very difficult to manage and can be associated with significant complications. We will go through the 16 guidelines that are offered as part of this document, just as a summary really, for you to be competent in managing such patients. All patients with suspected supracondylar fractures must have a documented radial pulse, capillary refill time, and a documentation of the function of all the individual nerves, the radial, median, ulnar, and anterior interosseous. These injuries require early surgical treatment on the day of admission. Nighttime operating is not necessary unless there are indications for urgent surgery, which include an absent radial pulse, clinical signs of impaired perfusion, and threatened skin viability. Surgical stabilization should be with bicortical wire fixation. Crossed wires, as discussed earlier, are associated with a lower risk of fracture reduction, whereas divergent lateral wires reduce the risk of injury to the ulnar nerve. If a medial wire is used, techniques to avoid the ulnar nerve should be employed and documented in the notes. Wherever possible, 2 mm wires should be used to achieve stability. Cubitus varus should be avoided by achieving a carrying angle or a Bowman's angle similar to the contralateral arm, roughly 70 to 75 degrees. The majority of injuries in supracondylar fractures, the majority of nerve injuries in supracondylar fractures are transient neuropraxias, specifically of the anterior interosseous nerve. If there is concern of a iatrogenic injury, then a thorough assessment with consultant input is required for consideration for nerve exploration. The majority of vascular impairments resolve fracture reduction. A pulseless, well-perfused limb does not require brachial artery exploration. In the case of a child presenting with an ischemic limb, the case should be discussed with the vascular team prior to fracture reduction. If the limb remains ischemic after open or closed reduction, then exploration of the brachial artery is required with a surgeon that is competent to perform small vessel vascular repair. This is usually a vascular surgeon. It is paramount to document postoperative neurovascular status until you are confident that there is no risk of vascular compromise. Suspicion of compartment syndrome or deterioration in perfusion should prompt immediate vascular reassessment and intervention. Postoperative x-rays should be obtained between 4 and 10 days to ensure maintenance of reduction. KY removal and mobilization is typically recommended at 3 to 4 weeks. This can be removed in clinic. And finally, routine follow-up is not required. Thank you very much for listening to this podcast.